Hey, Dr. Mike Franco here, board certified hand surgeon at Cooper University Hospital. We're at one of our great offices in Moorestown, New Jersey. I'm here with some of our great occupational or hand therapists. We can say hi to my great teammate here,
Hi, I'm Alexis McCollum, Occupational Therapy.
Alexis, and my other great partner.
I'm Elsa Starikian. I'm a certified hand therapist here at Cooper.
Amazing, certified hand therapist. So at Cooper, if you come to see us for carpal tunnel, a broken finger, a broken wrist, brachial plexus injury, which would be much more serious, you'll see teammates with our hand therapy team that we can meet today. So we'll start. Alexis, what's a very common thing we see in our hand therapy office?
We see a lot of carpal tunnel syndrome and carpal tunnel releases.
Okay, and what do you identify? What would you say if I could tell me as the surgeon, if I could give the patient advice ahead of time, what do you hear like, oh, I wish I knew this?
Move after surgery.
So I should really be encouraging patients, hey, keep those fingers moving. And do you sense it's because patients are in pain, they're reluctant, or they're nervous, like, oh, was I supposed to move my hand?
Probably a little bit of both. People are nervous to move after surgery because you think you just had surgery, you should really stay still, and it's painful. But either way, you want to stay moving.
We want to stay moving, okay. And if I said, do you ever hear like patients say, yeah, Tylenol and naproxen are enough, and then I can get my hand moving if we encourage them like
Absolutely.
around the clock for the first 3 to 5 days?
Absolutely.
So keep moving. Okay, we got our message from Alexis. We're going to keep moving after surgery because that's important in our simpler cases, even carpal tunnel. And then we'll put Alyssa on the spot here. And when you see folks, okay, we've kind of said carpal tunnel, maybe something complicated like a broken finger, I don't know, or something. What do you see where you say, boy, this is gonna be tough? How do we get folks through it?
Definitely like post-op fractures can be difficult.
Yeah.
Swelling, pain, post-op precautions.
Got it. And again, in these more complicated recovery periods or therapy situations, are folks bringing you something like, oh boy, I wish the surgeon could have told me this, or wow, I wish I had this set up in my house because I can't even open a dang jar to feed myself? Do you hear things we can prepare them better for?
Occasionally, but I think you guys do a good job preparing them. I feel like a lot of patients are aware of what to expect, and we try to help guide them along the way.
Got it. Okay, well, how about in a specific fracture? Let's think, we can kind of pick our brains here. Let's say we have a 65-year-old female. You're reasonably healthy. You come in, you say, oh man, I was walking my dog and I didn't see the other dog and my leash got twisted and I have a small finger fracture. It's the base of what we call our proximal phalanx, or the bottom of the finger here. It's on the x-ray, they told me the urgent care is pretty crooked and I need a surgery. I then saw Dr. Franco and he said, well, I think we can get you through with splinting and early motion.
Sure.
Have you seen these situations?
Of course.
Okay, so we see that finger, it's crooked on the x-ray, it's kind of pointed. We see the zigzag, and then I say, well, if it was my hand, I'd start to get in a protected position and start moving. How do you treat those folks?
Depending on collaboration with the surgeon, we could do like buddy strapping for
That's
early
it can be that simple, right? And
activation.
if folks with broken fingers, they're scared, but you might say like, look, if you just tape this and protect it, no heavy lifting, but you just start moving, it's gonna do okay.
Absolutely.
Yeah.
And then they're gonna look at the x-ray and say, well, did you see how crooked it was? And what I would be telling them like, well, the x-ray is one part of the story, but it's really about your motion.
Yeah.
So besides the buddy taping, how about, we'll go over here,
Sure.
how about custom splinting, that
Absolutely.
thermoplastic, you heat up the stuff, that amazing little
Yeah.
bath, and then talk about the position we're often trying to get the hand
Yeah.
in.
So we try to do that intrinsic plus position.
So we're kind of doing like this little sock puppet shape here, and that's we call it you may hear this lingo, we say intrinsic plus. This is sort of the position your hand wants to be in to maintain a posture that can be very workable. The opposite would be the position where we can end up with sort of this claw hand that, we don't want to set you up with that. So, okay. So we say, can we get them in a splint?
Absolutely.
Could you do it the same day they see you for the workup?
That would be
or the next
ideal.
day? Yeah.
And then they have something comfortable to go home and sleep in.
Right, so a broken finger doesn't mean surgery every time, especially for me in our patient population. I don't want to say older, physiologic, you say, hey, I'm still healthy, we need to walk the dog, drink a cup of coffee, and take care of my house. I wouldn't want a surgery on my finger. So therapy is very important, and position of protection, or just some buddy taping and say, hey, feel empowered to move your hand. All right, so we have carpal tunnel, we have a broken finger. Now we'll kind of bounce back and forth with something that's definitely complicated. It relies a lot on me to do a good job, and then a lot of work after the surgery, which is my poor folks with a cut tendon, we call it a flexor tendon, that lets you do this. And we often say that, oh man, this is really hard because it's in zone 2, or this really tricky space in your finger where there's very precious real estate and everything counts. So okay, I see a patient, I repair them, I say, yeah, it's a solid 4 to 8 strand repair. I say we can confidently start moving them. When should I get them to see you guys? Here, we're gonna have Alyssa scoot in and board. I can't, just make sure you're seeing.
Sorry.
Alyssa, how soon should I get them to you? If you're thinking like, I want an early motion, it doesn't have to be active, but we want them really moving. When should I get them to you?
3 to 5 days.
So we're gonna get you there early. So if you see me with this cut finger, which happens, we wanna make sure we communicate with each other, and it's my job to let you know we have a surgery, but that's just the beginning of a 3-month road of hard work. So we're gonna get you to Alyssa in 3 to 5 days. And then you're gonna say, well, it's still got stitches and it's still scary, but what do we have to help them do?
Depending on if it's passive protocol, early active, you want to make sure that the scarring heals appropriately when we get them moving. Eventually get them ready for like scar massage, things like that. Get you in protective splinting.
Got it.
Things like that.
Yeah, so again, we're hearing moving, that's the key, because if we just, I don't do a good job communicating, or we're a little worried because it's gonna hurt, and we sit there in my post-operative splint and then you don't move it, this healing around it, we sometimes say extrinsic or scar healing around the tendon, now you're stuck and we have a big problem, hard to get, once that sets in after maybe 10 days, really hard to get the ball rolling again. And then for Alexis, what do we think about for these folks as far as positioning in the splint and giving them some exercises to do at home?
Absolutely.
And how much should they be doing that?
Absolutely. So position in the splint is kind of similar. We try to keep the wrist in a neutral position. These knuckles in the back bent a little bit, and the tips as straight as we possibly can.
Yeah, there we go. I see that. Okay.
And now we'll have them in the splint full time. They're only removing it for intentional hygiene if they need to do dressing changes at home. And for exercises, I even have them stay in their splint and just unstrap to do it. The exercises really like 5-6 times a day.
So that's
you
a
want
lot.
them moving. It's a lot.
Right, like if you have it, you say, well, I have to go back to work, I'm gonna work one-handed, and we're saying, well, you have to take 15 to 20 minutes 6 times a day. I'm not sure, I'd have to be very motivated personally to do that, but then we will encourage you, you need to be motivated, because I've seen these, when I think I did a good job, you're very willing to try to get to heal. We have great therapists, and then we end up with a really stiff finger that wants to curl up and not straighten or bend. That's a bad scenario to be in after a tendon injury for getting back to life.
Or another bad
Please.
case scenario is
Please,
when
yeah.
you ruin the repair. That's why it's important to stay in the dorsal block
Right.
orthosis, because if you pull back, you could rupture the tendon that can be repaired.
Right, so early on, while I'm encouraging motion, and I want to, sometimes I'm a little bit maybe overly optimistic, and I use phrasing like, yeah, let's get you moving, and people say, oh, you said move it. Well, we're actually protecting the position again. We're not passively or pushing and say, well, what if I push it? We don't know what that darn tendon wants to do yet. Now there are protocols when we can ask you to try to actively extend there, even outside. If I did this with a patient wide awake, I might even say, all right, try to extend that thing actively, meaning you're getting these cues from your tendon, your muscle belly, pain receptor saying that's safe. But if you took it and pushed it, that's a little different, right?
Absolutely. We like to say move it, don't use it.
Yes.
Move it, don't use it. Okay, and now let's think about something. No, I don't do too, this maybe push me to say, like, what about our wide awake tendon repair I do, where I'm watching the patient the whole time and I say, wow, I did a good job, the setup was good, and I'm watching them be able to make a full fist gently. So even though we know that's a lot more force than you would think, they're still safely gliding. So I'd say, okay, I'm comfortable with them doing a full fist, and I'm comfortable when they open at least to a reasonable extended finger. Can we start them with early active motion?
Absolutely.
Okay. Tell me what's a bit about early active motion.
So early active motion, we're going to start off with some gentle exercises still to get it moving, where we're doing it together, and we'll teach you before you go home. But then we have them doing just short arc, active
Short arc.
bending, not the extension, extending only to the bounds of the splint.
Right, but they're doing that under their own power. The muscle in this hand, and we're not relying on us just kind of manipulating with the other hand.
Absolutely, yeah. So passive motion, you do all the motion with your opposite hand. Active, it's the actual surgical hand.
Got it. And now, Alyssa, have you seen any factors? I always want to be critical and say, boy, what could I do different? Now with these like maybe more complicated things like a tendon repair, Have you said, oh, I wish the surgeon communicated this with me, or I wish I knew this about the surgery so I could either push or not push, or boy, I'm looking at the hand and I would have wanted this a little different. What are some nuances you see as a therapist that could really help me with the patient?
Yeah, luckily, communication is pretty good, especially with more significant cases. And if we ever have questions, obviously the therapist will reach out, confirm with the surgeon, confirm with you know, PA or nurse practitioner that he works closely with, just to make sure that we're following everything that we're supposed to.
Right. So I need to give you the information. Like I said, I need to say yes, this was a solid repair, and we can get them moving. Or how much do we need to protect it?
Exactly.
And then have, you know, because now I've seen different versions in my office. Have you seen ones where you say like, look, I've seen the surgeon must have done at least an okay job, and then I've seen the patient do the work, and we've seen real success stories after a zone 2, meaning a tendon cut again in this part of your palm.
Yeah.
Because they're hard. I've seen
hard.
not success stories, and based on a lot of factors.
Yeah.
But we know we can get
But
outcomes.
absolutely.
Yeah, and there's other things like if they require like a tenolysis down the line, like there are other operations that could help with their success.
Right, like the tendon. Sometimes we do need to go back in, even if we all have done a good job, and clean out scar tissue along the tendon. All right, well, I think I've taken enough of your time. Our great therapist. We're learning today in the operating room together. It's amazing. Thanks for your time. And we don't do any edits, so you're going to see me hitting the off button now. Thank you so much.